So thank you, everyone, thank you, Francesca, for inviting me. Thank you for everyone for attending. We hosted a similar conference last year in San Francisco, and in fact, a lot of the clinicians and researchers and families that are in this room came together to actually discuss this protocol. So it's exciting to see all of those collective efforts come to reality. And although we are very, very early in the trial, it's exciting that we're actually able to enroll patients, and for that I want to thank the families, not only for often donating skin to all these brilliant researchers that can better study models of epilepsy, but for trusting your children in our hands for these types of studies. So, so we've already talked a lot today about PCDH19. I just wanted to summarize some of the bullet points. We know that it is a transmembrane protein of calcium-dependent cell adhesion, and certainly the importance of that is being worked out. It's involved in synaptic formation and transmission. We're learning that mutations lead to impairment in GABAergic signaling. And most exciting is this indirect evidence that has been linking progesterone and allopregnanolone to seizures, and the possible relationship of not only seizure onset in the slide shown by Joseph in the mini-puberty, but also offset as that relates to allopregnanolone levels. So as an epileptologist, when I started learning about some of these basic science discoveries, it was very exciting to think about moving forward with Ganaxolone as not just an anti-epileptic drug, but was it an anti-epileptic drug with some other metabolic effects? So as Albena commented, we started out on this open-label, multi-center trial. The initial goal was to enroll 10 pre-pubertal females. The treatment phase was going to last for 26 weeks, and depending on the age and size of the child, that would determine whether they received oral suspension or capsule. The primary endpoint is going to be the % change in seizure frequency per 28 days, with a secondary endpoint of hopefully an increase in the intercluster interval. The inclusion criteria were fairly straightforward. Had to have a parent or guardian that could provide informed consent. Initially, the children had to be older than 2, but less than 11. However, as Albena mentioned, there were some patients that really wanted to enroll their daughters. So we were able to get some amendments and include those children as long as they were still premenstrual. They, of course, had to have a confirmed PCDH19 mutation, be on a stable anti-epileptic drug regimen. And this last bullet point here, a parent guardian able to maintain accurate and complete seizure calendar, may come as just a given, but this is extremely complex, and I know as the topic of many epilepsy studies, it's the best we have in terms of seizure counting. But when it comes to children who are having clusters of seizures, how one defines those clusters, how one counts those clusters is actually extremely challenging. This is how we last summer, chose to define what is a cluster seizure. And again, this was a group of clinicians sitting around and essentially making this up. So the seizures had to have at least 10 seconds in between offset and subsequent onset, where the child was thought to be back to their baseline. The cluster itself had to last for more than 1 hour. So if a child had a single seizure, then 10 minutes later had a second seizure, and then that was it, that was not counted as a cluster. Rather, those would have been 2 individual seizures. And the intercluster interval had to be less than 6 weeks. And herein lies one of the main challenges that we discussed yesterday in our workshop of the wide variability in terms of how these children go in between clusters, but having to set some endpoint for inclusion so that we may actually be able to see what the efficacy is when the drug is introduced. Aside from having cluster seizures, for those children that were actually having non-cluster seizures, they could also get into the study if they were having more than 4 per 28 days. Exclusion criteria were also pretty clear. They could not have had a known sensitivity to Ganaxolone. They could not have been on any other investigational drug. This is also assumed their seizures could not have potentially been due to a secondary cause, and concurrent use of certain anti-epileptic drugs or other medications that led to severe inhibition or induction of the CYP3A4 enzyme was exclusionary. The dosing, again, this was an open label design. It was a flexible and non-forced titration, which, as I spoke with some of the other investigators yesterday, I think we all did it pretty much the same, but because these children do have widely spaced seizures, we would often wait to see if the initial dose was in fact effective, and then if a cluster occurred, the dose would be increased. And so this is going to be important because although we have 9 patients that were enrolled in the study, many of them are actually only 8 weeks into the study, and being only 8 weeks into the study means they have been titrated over the first 4 weeks, so really have only been seeing the maximally tolerated dose for about 4 weeks. We could then increase the dose every 3 days at our choice by as little as 20%, but by as much as 50%, and that was often dictated by the capsule size or dosing interval of the liquid. And then the maximum dose, as shown by the other studies that Albena showed you, was 1,800 milligrams per day or 54 milligrams per kilogram per day, not to exceed the 1,800. Here's a list of the 8 sites from the US and Italy. And this is just a quick overview of the schedule of events for the study. You can see it's pretty standard. There was a baseline period that had to have 12 weeks of seizure data, and then they were followed every 4 weeks for the first 2 months. Then those visits were spaced out to 17 weeks and 26 weeks, and 26 weeks is going to be the primary endpoint at which we will then decide if there has been a benefit and whether or not the child can continue on the open label extension. We recorded seizure calendars at every visit, reviewed them in detail to make sure that we were speaking the same language, EKGs, vital signs, and some other measures of clinical change, such as just asking the family, what is their subjective impression of how the child is doing? Are they mildly improved, or much worse? So we all knew that this was a challenging epilepsy syndrome to study. I think what we learned so far is, even though we know there are lots of patients out there, in order to get into the study, the inclusion criteria was actually quite difficult. People at Marinus called around to many of the major pediatric epilepsy centers in the United States asking, how many patients do you have? And a lot of the times we got an answer of 1, 2 patients, and if you only have 1 or 2 and one of them is actually already doing well, it makes it difficult. We at UCSF follow about 15 girls and could very quickly enroll 2, and I have about 5 right now that are just sitting out there and having a seizure about every 8 weeks, so they therefore don't meet inclusion criteria. We know that this is early onset seizures. We know it's more than just seizures, as families can attest in the audience. There are certain cognitive and psychiatric and behavioral comorbidities that we don't really know if they are related to seizures or not. And I think what we have realized is that with this huge variability, it makes it very difficult to tell whether or not our drug is actually going to be effective. And I think this is true and is the collective experience that do the drugs, any of the drugs that we have, what impact do they have at all on the overall seizure frequency, or do we just need to have a mechanism by which we can treat the clusters more effectively? So here are the brief demographics. So 9 females, they're all Caucasian. You can see the age range here as young as 4, and the oldest is 14. This is a list of the varying mutations, including one who has a deletion of the entire gene. And rather than show a table of the 9 patients that really, I had a table like that, but it got very busy, we basically just broke it down into these 3 sort of bullet points to show you that we are capturing those children that have the more severe phenotype. So these girls had between 1 to 57 individual seizures per month, and when we averaged that over a 3-month baseline, it was between 1 and 34. They have between 1 and 16 clusters per month with a 3-month baseline of 1 to 9. And then the seizure-free days per month. So again, that inter-cluster free interval range from 6 up to 26 days, again with an average of 9 to 26. So here's the slide that I think all the families have been waiting for. So in the end, again, we just enrolled our very first patient at the end of April, and so she is coming upon her 26-week visit actually in 2 weeks from now. The rest are very early on in the study. But so far what we've seen is that 63% of the girls have experienced a 50% reduction for at least one 28-day treatment period. Now I know that's a very loaded bullet, right? And this is where it gets challenging, because one can have go 14 days in between seizures at baseline, and then we start the drug and they go 30 days, and that is deemed a success, only to see that the next month that they go back to having a seizure every 20 days. So we're really trying to figure out and not sugarcoat this in any way, but also not give up prematurely, because we clearly are seeing some of these girls who are having, where the drug is having a positive impact. The safety data, it is very well tolerated. I think we have all pushed our patients up to the maximally tolerated dose, which is consistent with what has been seen in the other trials. We did have one girl who was seizure-free, but had to discontinue treatment due to a rash that was thought to be possibly drug-related. And another responder that showed a huge variability in response looked, again, in the very beginning, that she was going from having up to 60 seizures per month, and then the first month on drug was seizure-free, only to see then the seizures creep up over time over the ensuing months. So this is something that we struggle with in lots of new compounds that are introduced into our refractory patients. Those patients that are currently enrolled in the study are continuing to receive treatment and have been on it from 1 to 4 months. And so we hope to have follow-up data on these remaining girls in the next 4 to 5 months. And one thing that we really have noted, and I know that this is an open label trial that has a lot of its own bias, families want this to work, and is why we need placebo-controlled trials. But I will say that the 2 patients that I followed, both parents had noted marked improvements in behavior that was actually offered up in one scenario by a teacher who did not know that the child was actually on a clinical trial. So there, I think, something else there that may actually be independent of seizures, and how we actually objectively measure that, whether it be with behavioral checklists or actual formal neuropsychological testing, I think is going to be a struggle. Lastly, this is data that we just received on Tuesday from the 3 patients that were in the study long enough to have baseline allopregnanolone levels checked here in the first column, and then their follow-up allopregnanolone levels at week 18, followed by their pregnenolone levels. And what you can see is a dramatic increase in the allo levels. Now, we've asked some of the other people you've already heard speak today, how do we explain this? And we can't. So when we can't explain something, the first thing to do is go back and make sure that the results are correct, and we plan to do this and repeat the assay. But if this is correct, it does raise, I think, a lot of interesting questions as to what could be going on in these children. So to summarize, this is a rare condition, and at least the type of children that we need to enroll in this study are even more rare. We definitely see some signs of some early potential responders, but in all fairness, we also see some children who do not seem to have any impact. There are lots of anecdotal reports of improved behavior. We feel that we have found the maximally tolerated dose, and it is safe, and so stay tuned as to whether or not the remaining girls have a more favorable response that we can report back to you soon. So thank you.
I have just a little question. the reduction of number of seizures were consistent with a reduction of a number of a reduction of clusters of seizures.
Yeah, so the question is the reduction in seizures, just number or in number of clusters? It's very difficult to answer that question. It's actually both, but not always the same. So there were some children that had a reduction in their individual seizures. There were some that had a reduction in their number of clusters. However, the number of seizures per cluster remained the same. And there were some children that had the same amount of clusters, but the number of seizures in each cluster was reduced. So it was really, and only in 9 patients, it's difficult to tease those things out.
Sorry, just a question. When you speak about the allopregnanolone levels on the blood, is it possible to perform dosing in the cerebrospinal fluid?
You know, I don't know the answer to that. Is anyone else in the
There are some.
Joseph, Giuseppe? Yeah. It's possible.
Not an easy way to do. No, it's a very good point, and would be good to know whether the cerebrospinal fluid levels change and how they change, because this is a very important question. Not necessarily in these girls, of course. We would like to know what the levels are even in normal individuals and compare it between the blood. So maybe that would be a good starting point to look for the opportunities when this fluid is taken in especially younger individuals of that age and girls, and to compare, because we can use that as a proxy, because that's super important.
Interesting to know if giving orally the drug, you can increase the level of the cerebrospinal fluid. I think is very important.
It's a very interesting, it's complex, but I just don't want to say that it's good or bad. It's some good feeling, but it's a small study, of course. It's going to be very important to see at the end point. So when do you think that you may have the data perhaps collated to make some important decisions? Because, of course, this whole exercise, it's costly. Not everybody probably realizes it. It's a lot of work, even for 10 patients.
Right.
So it's going to be very important to sort of to regroup, and you and the company and the others will need to make really the important decisions, what the next best step is going to be.
Exactly. So there are 4 girls that are still actively receiving drug, some of whom are 3 months from our Italian colleagues here in. And so they will be having their allo levels drawn at the next visit, I suppose. And so it should only be 4 months from now when all of the patients that are currently enrolled, we will have allo levels from. As part of the working group yesterday, we discussed that because we had a few early responders but had to terminate because of either rash or a dramatic sort of bump in seizures that was unexpected but was likely the natural history of the disease, we would like to actually enroll a few more patients, so we at least have 10 that have completed, right, acknowledging that that's still an extremely small study sample. So I think we'll have at least 7 of the allo levels in the next 3 months, with a few more as long as we can get some patients enrolled.
So, and we as a company, we have been thinking about what do we do with this study, especially in case the results may not be the results that we can go to regulators and say, give us the indication. So pretty much our plan is that we will have this drug approved for children for the larger indication, which will be partial onset seizures. And eventually the drug will be available, and it will be trial and error in case we don't specifically go for PCDH19. But again, it's too early for us to say yes or no, but at least as a way for the future, the drug will be available to pediatricians as a general anti-epileptic, if not for PCDH19 specifically.
Okay.
Thank you.
Just a comment.
I'm sorry, this is a question that I had about the trials in general, because there's a Fragile X trial that's a double-blind that's going on, and I'd like to know, in line with this question that Joseph just asked, when do we think that trial is closed so that we have information in that too? Because if the drug is available for pediatricians, one might think of using it on other, and Fragile X is the next logical way to go.
Very. Non lo so.
Well, we do expect the Fragile X data to be available by the end of this calendar year, so it's like the final stages of cleaning the data, and probably by around the holidays we'll know the high-level results, and those will be communicated. And yeah, as Joseph said, they are very closely related, so we are excited to see what the Fragile X brings us. I don't think we have allo levels there. So then again, the big question on the table, what do we know about allopregnanolone, will still be there. But at least we'll know whether we do see improvement in behaviors, because in the Fragile X study, we do have just behavioral endpoints. It's just, we don't even count seizures there, which I don't know if it was a good idea, but we'll see.